So I invite Dr. Saritha VK, Professor of Ophthalmology, Government Medical College, Kottayam, for her talk on Gonioscopy.
Good afternoon, everyone. Thank you, madam. The topic is gonioscopy. Straight away coming to the indications. Basically, it is to differentiate an open angle from a closed angle and to study the topography of the angle and also use for therapeutic purposes. A word about the principle. Normally, we cannot visualize the angle structures due to total internal reflection at the cornea-ear interface. Coming to the principle, the gonioscope changes cornea-ear interface to lens-ear interface, changing the critical angle, thus permitting the view of the angle. There are two types of gonioscopy, direct and indirect. With direct lenses, the light is refracted from the angle is observed directly and we get an erect image. With indirect lenses, the light is reflected by a mirror within the lens and an inverted image is obtained. We usually do indirect gonioscopy and this is the standard procedure. As I told, with indirect lenses, the images viewed are reversed by 180, but the right-left orientation remains the same. From the figure, you can see that the pigmentation at the 12 o'clock is seen at the inferior mirror at the 6 o'clock position, but the PA is seen on the same side. These are the indirect gonio lenses, Goldman. We usually use Goldman 2-mirror lens, which has got a flange and it is used for manipulative gonioscopy also. These Zeiss, Posner and Sussman, they are mainly used for indentation. Regarding the procedure, the key points are the gonioscopy should be preferably done in a dimly lit room. Regarding slit lamp adjustments, there should be minimum illumination initially and with 10x magnification. Use a thin short slit beam. The purpose is it should not cross the pupillary border, producing meiosis and which can artifactually opens up a narrow angle. First of all, you have to explain the procedure to the patient after anesthetizing and filling the lens with the viscoelastic. You can examine the lens for any bubbles or oil marks or scratches. Then the slit lamp adjustment is made. You have to reduce the slit beam and ask the patient to look upwards, pull the lower lid slightly down and place the lens. You can see we are supporting the gonio lens with 2 fingers and the third finger is used as a support to the headband. Then first of all, you have to focus the inferior angle in the superior mirror because that is the widest angle. Grade the angle, then you can increase the illumination, you can broaden the slit beam and look for the final details. As you all know, this is the normal angle anatomy. Starting from the Schwalbe's line anteriorly, the non-pigmented and pigmented trabecular meshworks, scleral spur, ciliary body band, and finally the root of the iris. So what is an occludable angle? When the non-pigmented trabecular meshwork is not seen in 3 quadrants of the angle, without indentation or manipulation in the primary position, it is called an occludable angle. The corneal wedge can be used to, the apex can be used to identify a Schwalbe's line so that we can differentiate a pigmented Schwalbe's line from the trabecular meshwork. What about manipulative gonioscopy? It is done with Goldman lens and useful in convex iris configuration, and over the hill view is obtained in a narrow angle and the patient is asked to look towards the mirror and the mirror is tilted towards the angle being viewed. Coming to indentation, we usually do with Zeiss or Sussman lens, which has got the same radius of curvature as that of the cornea. The apex is indented and we can differentiate an appositional closure from a synechial closure. This is the procedure of doing indentation. This is a closed angle. We can see after indentation, the angle is opening up. Coming to the disadvantages, these indirect lenses require a coupling medium. It has got a mirror image, and inadvertent pressure can open or close the angle. These are the direct gonioscopy lenses. The advantages are we get an erect panoramic view which is relevant for surgical procedures. There are different angle grading systems. The most popular and usually used is the Schaffer system, which is based on the angular width of the angle recess. And when the angular recess is less than 20 degrees, there is a chance of closure of the angle. How do we represent angle structures? We represent angle structures by the most posterior structure seen first in the primary position and then on manipulation or indentation. We can also represent the trabecular pigmentation, convexity of the iris or peripheral prominent role of the iris, and subtle features like peripheral anterior synecdoche or new vessels in the angle. This is a representation of the goniogram. You can record the finer details like NVA, goniosynecdoche and peripheral anterior synecdoche. What are the contraindications for gonioscopy? If there is acute trauma to the globe, bulle, ocular surface infection and epithelial defect. There are some of the gonioscopic findings. Iris processes are fine filiform, they don't obstruct the underlying structures and follow the contour. Unlike peripheral anterior synecdoche, which are broader, tent-shaped and obscure the angle details. The new vessels, they are fine, arborizing and crosses the scleral spur. We can see the double hump sign on Plato iris, pigment dispersion, concave iris configuration, Sampolasi line and a homogeneous dense pigment. In pseudo-exfoliation, there is patchy pigmentation of the trabecular meshwork. This is the prominent Schwalbe's line in accent field rigor. And iridia, there is anteriorly displaced rudimentary stump of the iris. These are the irregular pigmented widening of the trabecular meshwork in angle recession. Also, we can make out cyclodialysis and foreign body in the angle. Don't remember to check the patency of the ostium after trabeculectomy. Cleaning, usually we clean with soap and water. The take-home messages, in ideal conditions, gonioscopy should be done routinely for all patients above 40 years. It is a must before making a diagnosis of glaucoma, and repeat gonioscopy at regular intervals during follow-up of your cases. Thank you.
Thank you, Dr. Saritha, for your elaborate but basic things how to do a gonioscopy. Because gonioscopy is critical in the diagnosis of all forms of glaucomas, which will give an information about the increased intraocular tension, and also it is critical to see the potential causes, determination of therapy. So for therapy as well as cause of increased IOP, you can find out by gonioscopy. So all general ophthalmologists should know how to do a gonioscopy.